Okay. Okay, good morning. I'm Carlos Pereira Alves from Portugal, Lisbon. I'm a doctor, a surgeon, and I'm at the present time the president of our Portuguese Association of the hospitals. So I will start it on behalf of our association, our Portuguese Association, and on behalf of myself, to congratulate the União Catalana de Hospitales and to congratulate the HIF for this splendid congress, as usually, and especially now for us Portuguese in this splendid country that is Spain, and in this splendid country, city that is Barcelona. As you all know and are aware, COVID is I usually call that is tragic and unexpected, and have obliged us and leave us to take some lessons and some measures. And I remember that some years ago I have been in a top managers course in INSEAD Institute, French Institute of Public Administration, and the course was called Avirá. And Avirá makes my mind here that is exactly what I'm wanting now. That's say Avirá is mean action. We need action, urgent and important. We need vision. We need innovation. We need responsibility, and responsibility that is at the same time collective and individual. That says a responsibility that involves the citizens, involves the professionals, health professionals, involves the politicians, the scientists. And last word was awareness. We need to be aware of looking to the results we are obtaining, and looking to follow up and see what will be the next measures. My last remark has to be that is the key, for me, the key importance of this pandemic is that put in the agenda the solidarity. And I think solidarity nowadays is essential, and I think that is an intelligent selfish, because we are completely aware that we cannot stop the virus locally if we don't stop the virus globally. So I think it's time anyway in this tragic situation to follow. Yesterday I visited a small representation of the painter Max Chagall here in Barcelona, and there was a phrase that is from Max Chagall, that have crossed 2 mundial wars. And even that, he said that although the tragic times, we should not lost the hope in man, in mankind, and the hope in love. So I think this is the principal lesson that we have from this. After that, we should go straight away to our program. I also congratulate the speakers and thank you very much for being with us. And we'll start with Margarida Aires, that will make his talk. Margarida is a professor in the high school of Lisbon of technologies, health technologies, and his main interest is in quality and patient safety. So, Margarida, the floor is yours. Go ahead.
Thank you very much. Good morning to you all. Is that this? Yes. As you see, we are trying to talk about health professionals that were across the last nearly 2 years working in hospitals. And we try to study their experiences and talk to them in order to know something about their experiences. This is my agenda, and as I already told you, the COVID-19 was, as Professor just said, something that came suddenly with no announcement, and which was really tragic, and all healthcare systems had to adjust, and obviously the healthcare workforce as well. So there was a really need to rapid adapt and adopt new ways of working. Our purpose is to highlight the importance of patients' and health professionals' safety as an essential requirement for safe health systems, to identify new forms of management and organization and new healthcare practices, and to recognize the adaptation or creation of new functions within the teams as a response to the new needs. So we had an online survey and all the respondents were healthcare professionals from hospitals around Portugal. We collected the responses between the 9th of September and the 7th of October, so within a month, and we had 140 respondents, mainly female, which is quite expected and normal, and let me see if I can, yes, mostly quite old people for healthcare, obviously, but also a few even older. So you can see that in Portugal, mainly we have people working above 45 years old. And most of them have a university degree, and as you can see, there is also a lot of people already at least with a master's degree. These are the regions, the Portuguese regions, and we also included the islands, Madeira and Azores. So most of the people are from Lisbon and the area around Lisbon, and afterwards we have people from the center and from up north. As usual, mainly nurses respond to these type of surveys. But obviously we also have hospital managers, physicians, and technicians, but actually most of the times nurses are more open to answering these type of surveys. These are the areas that had to be adapted or changed during pandemic, and you can see that these four are the main ones. So you have reorganization of circuits, you also have healthcare delivery and quality and patient safety and processes. These are the areas where the adaptations had to occur. So here you can see how people answered when we wanted to know where they had to reinforce the responses after the pandemic started. So you can see here and here implementation in the service of infection control and prevention programs, as well as occupational health and safety programs that include protocols which guarantee safety and prevent infection by SARS-CoV-2, and also with the same percentage, clinical management of COVID patients, like planning and preparation of circuits, transfer of information between shifts, approach to critical and non-critical patients, treatment of specific patients such as geriatrics, pregnant women, and children with COVID-19, rehabilitation and palliative care. We also have education and training, which was considered important to them, and here remote care something that we usually didn't use before COVID so much as we started to do, and it maybe continue being used after COVID ends, which is telephone follow-up and tele-appointments and tele-rehab, actually using digital health. These are some examples of main areas where changes and adaptations happened. We kind of grouped them in 4 different groups. One of them is reorganization of circuits, processes, healthcare delivery, and new functions and practices that occur. I'm not going to go through all of them, but mainly you can see infrastructures and palliative care unit visits, for example, some video calls for patients because they couldn't have their relatives nearby, and virtual meetings and training, actually most of them around digital health again. Here we can see reallocation of beds and infection control routines and procedures, which already were in place, but with COVID they change a little bit, and again virtual appointments and so on. When we asked, will these new ways of working remain after the end of the COVID pandemic, you can see that people consider that some of them will, and 35% consider that all of them will. So it's quite interesting to see that people kind of started to do a few things that will mainly remain afterwards. And some examples of these ways of working are virtual meetings again, information integration processes, and virtual appointments, new infrastructures and separation of circuits, and reinforcement of patient safety practices. Actually, patient safety is a key issue. Best practices in patient safety and health professional safety. We asked if they really recognized it, and as you can see, 76% recognized an improvement, and these improvements are related to infection control strategies, different circuits for different patients, risk management, hands hygiene and use of masks, availability of adequate protection and cleaning and disinfection of work spaces, telehealth again, and the vaccination, which in Portugal is quite good. Obviously, there are some barriers also, and some of them with higher impact on the practice, everyday practice. You can see several, but one which is very important is the lack of human resources, and I think worldwide could be a problem, but in Portugal we really felt this problem quite deeply, and the burnout felt by staff. This is a topic that has been on the agenda even for the last days here. Fear of contamination, management and leadership, absenteeism, demotivation, and communication in the organization, which is also a very important issue. Another question that we had, given the pandemic at this moment, my professional practice is, and most of them said, suited to current needs, which is important. And these are the words that people best described about the current moment, and the size of the word is the number of times that people talked about it or described it. When asked, considering what you know today, how would you like healthcare to be managed and practiced in the future? People suggested networked, for example, articulated work, by levels of severity, patient-centered care, preventive perspective, digital care and home care, disease management, and don't neglect all non-COVID healthcare, which is also a very important topic. Better and more physical resources, again, the resources, multidisciplinary participation, teamwork, systematic evaluation of resources, autonomous management, accountability, and performance bonuses, actually motivation. In conclusion, we can say that these results show many changes that emerge as a direct impact from the COVID pandemic, and healthcare institutions and their professionals have taken the opportunity to improve their care delivery. So new forms of management and organization, as well as new healthcare practices and functions within the teams, are identified, and patient safety was identified as a critical factor for the quality of healthcare and patients and health professional safety. Thank you very much.
Thank you, Margarida, for sticking with the time. And we have decided we have discussion at the final of all the presentations. So I just call for the next presentation. Will be done by Vanessa Ribeiro, that is working in one of the Ministry of Health, one of the sections, the ICSS, and she holds a public health formation in the health management and graduating in nursing, correct? Right. Good, so go ahead. Don't forget, 15.
Okay. Message, get it.
Yeah.
Good morning to you all that are in person in this room, and to all of those that are attending the session in the virtual way. I am Vanessa from the administration of the health system, that is a national agency in charge of the management of the resources of the Ministry of Health and the National Health Service. Human resources, financial resources, and also infrastructure. And we are also in charge of the commissioning of healthcare services. So what I bring to you today are some national level actions that were taken to support the management of COVID in Portugal. So the best way to start is to see some numbers about the COVID in Portugal. So in this graphic here, you can see the evolution of the number of cases in the blue line in Portugal comparing to other EU countries. So in the first wave of COVID, we had quite few cases. In the second one, the numbers grew. And in the third one, we peaked 10 times higher than the first wave, as other countries. And in the fourth wave, we had lower cases than other countries. So this is a graphic about the ICU beds in Portugal. Before the COVID starts, Portugal was one of the countries with the lowest level, the lowest number of ICU beds per population, which was not a problem in the first wave of COVID. However, in the second and the third, the number of beds available were much less than the needs. So the hospitals were trying to do their best, but even though they were struggling. So with so many needs in terms of ICU beds and such a limited capacity, the death rate increased. And in the beginning of 2021, we had a higher death rate than other EU countries. So in such a catastrophic scenario that happened to many, many countries, we needed a lot of staff, we needed a lot of medical equipment, and the public mechanisms that were in place for contracting and for purchasing medical equipment were not fast enough to deal with the needs on time. Also, on that moment, there was a high demand for ventilators and a shortage of them because of the high demand all around the world. So we needed to be fast. In this context, there was approved a national exceptional regime for public contracting and expenditure authorization. So when this regime was put in place, there was no need of pre-authorization for purchasing medical equipment, and the process of authorization for contracting staff was more agile. Also, all of the extra hours limited, all the extra hours limits were suspended, and it was allowed to contract retired doctors to fulfill the needs. Also, in this moment, there was a financial program with 9 million euros available that allowed to purchase more than 1,000 ventilators and to contract additional human resources. By August 2020, there was another centralized financing program with 26 million euros, and this time this money was for infrastructure and beds. And this allowed to expand 900 beds in 16 ICU intensive care units for needs that were already assessed by a commission specially designated for this purpose. And as you can see in this graphic, it was possible to contract 3,500 more health professionals, especially nurses and nurse assistants. But we had another problem. While the COVID patients were being treated, what happened to all the other patients, especially the chronic ones? They were sitting in the living room. So before the COVID starts, the system was already dealing with some problems because of the aging of the population and the increase of chronic diseases. We also had a high demand for emergency care and high waiting times for consultations and for surgeries. And all of these got worse with the COVID. So as you can see, we had a decrease in 26% between 2019 and 2020 in the number of hospital consultations. And we also had a decrease in the number of surgeries into 24%. And the patients were less referred to surgeries. So it was not just the COVID that required an exceptional regime. We needed to take care and to guarantee access to all the other patients. So there was another exceptional regime in July 2020 that with the purpose of incentivize first hospital consultation and surgeries to try to catch up the delay for these activities in the hospitals. And it was a success because the numbers grew during 2020 and the program was extended for 2021. Since 2018, the ACSS has been incentivizing the use of teleconsultation as an alternative model to the traditional consultations. However, as you can see in this graphic, the uptake was slow. However, with the COVID and the need to avoid contact and to keep the patients out of the hospital, there was a natural uptake of this kind of consultation, as you can see after February 2020. And from a central level perspective, this is a kind of model to further develop. So we have been incentivizing it by paying the teleconsultation at a higher price. Since 2018, also there was launched a strategy for hospital at home. In the end of 2019, there were 24 hospitals providing hospital at home to about 2,500 patients. And this response doubled when the COVID arrived. And of course, this is much better for the patients, and this is also another model that we need to further develop. And my last slide is to share with you that in Portugal, we are looking to other models of care, especially those that fit the needs of the chronic patients. The SCSS, with some hospitals, some local health units, and some primary care, we are participating in an European joint action with 17 other countries, which the main aim is to disseminate integrated models of care. So in our case, we are looking at the experience of the Basque Country, and we are trying to implement some of the features they have and adapting it to our own reality. Just as an example, we are now in Portugal trying to implement a population risk stratification approach, using some tools to predict future needs of care for the different strata of the population. When we have this done, we can have targeted interventions, like defining care pathways for the main chronic diseases, or implementing individual plans of care, or even develop case management programs. And regarding the healthcare professionals, there are also in the Basque Country some new roles that we would like to implement, that are the referral internist and the liaison nurse, that are roles very relevant to ensure the transition of care and the continuity of care. So the main message here is that the COVID shows that all the health systems were not prepared for an outbreak. But also it highlighted that most systems, and I'm here speaking for the Portuguese one, was not prepared for the treatment of the chronic patients. So we need to see this as an opportunity to reshape the system and to improve the care, the sustainability, and mainly its resilience for future outbreaks. And this is the end of my presentation. Thank you.
Thank you very much. Thank you very much, Vanessa. Well done in time. The next presentation will be online, because it's not among us. It's done by Patricia Pacheco, that is an infectious disease specialist, and at present time is the head of the infectious disease unit in Hospital Fernando Fonseca in Lisbon. So I think it's prepared to. Yeah.
Hello,
There it is.
my name is Patricia Pacheco. I'm infectious disease doctor at Hospital Fernando Fonseca, Amadora, Portugal. I'm going to present our work. It's a 24/7 internal helpline. It was developed as a tool to hospital safety during COVID-19 crisis. Let me present our hospital. It's located near Lisbon in a large suburban area with low income and social deprived area with many immigrants, mainly from the African countries. It's an hospital very tiny, but with 800 beds. And we have 3,400 professionals, both clinical and non-clinical staff. It's an hospital that in normal and regular basis is always under pressure because of the huge number of people that we have to serve. In March 2020, the wave was coming. We were seeing what was happening in other countries in Europe, namely in Italy, with the hospitals overloaded with COVID patients. And we define our pathways, our response in the hospital, but it was very rapid and very quickly that we had to make the change in this hospital. For that reason, and because it was so rapid and so an ongoing challenge that with a day-to-day evolution of science, of new politics, of new guidelines, and it was really necessary to adapt in real time at a rapid pace. It was very important to maintain the hospital safe because the risk of infections in both healthcare workers and patients was real, especially in a hospital that has so many beds and so little space. So we had to be very strong with the initiatives, with the pathways, and it was important that all the healthcare workers could be informed about this new guidance. It was very important because many doubts and anxiety can hamper the process. And for that reason, during the first months of COVID-19 epidemics, a 24/7 hospital line was implemented. And what was this line? It was a centralized communication line. It was dedicated to hospital professionals, clinical or non-clinical, and it was available from everywhere, inside or outside the hospital. Even at home, the professional could talk to us. It was provided by my team of infectious disease doctors and hospital infection control. And our decisions were supported by hospital administration. The objectives of this line was to answer clinical questions, to inform the professionals about the internal policies, the tests, the pathways, the protective equipment, and also to evaluate all the professions that had symptoms. And we had the power to decide about you don't come to work, you just have to leave work, or you are going to do the tests. And we were following the patients or the professionals with the infection or without infection. The benefits it was to detect in an earlier way the infections on staff or on inpatients, the early detections of inconformities and promotion of corrective measures, because the guidelines were published, but sometimes what is published is not what is happening in real life, and to prevent or mitigate the outbreaks inside the hospital and contribute to reduce anxiety and fear from the professionals, because they always could reach to us 7 days a week, 24 hours a day. And what was more important, and it was that we are we were here in the hospital, and it was very important to define some pathways, new pathways and new guidelines, because 24 hours a day we were in hospital by our professionals. because we were a team of infectious disease doctors and infection control doctors, we were not only providing information, we were trying to align the information that all the professionals were giving to us to decide new pathways, new guidelines. And it was always integrated with other sectors of the hospital, the occupational health, the drive-through tests, the hospital administration, the infection control team, the public health, and the primary care. As I told you before, the early detection of problems was translated into new hospital guidance, and this was done much before the national or even the international guidelines. For instance, the first major outbreak that we had, it was on March 2020 in an internal medicine ward that was a clean unit. The first case was detected in a symptomatic nurse, and after we have done trace contact, and a total of 15 cases were detected, 9 in healthcare workers in that sector, and 6 inpatients, and some were asymptomatic or with minor symptoms. So this we look at this outbreak, and because we have studied what was going on other countries, what were the guidelines, what others were doing, and we decide to implement the protective equipment also in the clean, so-called clean areas. The pathways were revised because in those clean areas, the professionals were feeling more safe and were sharing meals in a tiny space. And all this was revised. Also, we made from March 2020 a mandatory PCR for all the patients that were admitted at the hospital. Our case definition, or our suspected case definition for professionals, was also expanded. Not only fever, dyspnea, or cough. And we didn't need an epidemiological link with other case, or, for instance, at that time in Portugal, the tests were only permitted for those which came from areas from China or from Italy, and very, very soon we didn't do this. Also, what we implemented, it was the PCR test for all health professionals, including asymptomatic workers, and after a contact, not only preventive isolation, as was the rule, and it was the rule until this year, 2021, in Portugal, we have done this PCR test after a contact for all health workers at beginning and before returning to the institution, in order to keep the institution safe, to keep this hospital a safe place to be. Our hospital has been usually affected with COVID-19. It was one of the hospitals with more patients along those months. We have, until March 2021, 300,000 COVID patients inside the hospital. And the peak was in January with 385 patients. This was 62% of the hospital capacity. However, and even with this huge pressure on the hospital, I think the professionals have made it with serenity. And serenity is not the freedom from the storm, but peace amid the storm. And we believe that this internal helpline 24/7 has helped our professional and our patients to pass this wave in a better way. Thank you.
Thank you, Patricia. The next speaker is Miguel Paiva. Miguel Paiva is an economist with a post-graduation in health management, and at the present time is the CAO of an hospital in the north of Portugal, Entrador e Voga Hospital Center. Miguel, it's yours.
Good morning. Good morning to you all. I wish you very good Congress. I will speak you a little bit of an experience we made in our hospital dealing with some special patients, namely those who were treated in hospital beds and as a COVID, after the treatment, the hospital part was finished and they didn't have backup at home for social reasons, for lack of family support. And in the first times where we were fully occupied with our patients, we needed those beds and we couldn't throw away these people. And so we had to find a solution. I will talk a little bit about that. That's my speaking. This was CADCO's project. And it was really important for this reason I said. In the early stages, pandemic was verified lack of institutional response, because the question is, we have in Portugal always a lack of social response for elderly, especially elderly patients and social depressed people. And our hospitals have a lot of beds always with those people that are in the hospital, because we can't throw them away on the streets. This question was much difficult in the COVID times, because even the social institutions were fearless of fear of the COVID, didn't know how to deal with COVID, and didn't want to accept some of their usual patients. And so it was necessary for us to have a solution for that. Our institution, our hospital, as all hospitals, as we have seen here, were fully occupied on all the transformations on the COVID that we needed to do. People were learning how to deal with this like it was the first time. And so we knew immediately that alone we couldn't deal with this subject. So we made contacts with the city council and the social security organizations to find a solution combining our resources of all these parts. And this was the aim of this project, this institutional approach between different parts that usually are focused on their own subjects, and as the difficulty we had to join together in this project. We deal as Câmara Municipal with the Santa Maria da Feira, which is the city council where we are, where is our main hospital. Ourselves, Centro Hospitalar Entrador e Voga, we make the administration of 3 local hospitals. The Hospital São Sebastião in Santa Maria da Feira, which is 340 beds. The Hospital São João da Madeira, which is more for ambulatory care, and Hospital Oliveira das Meias, which is a 40 beds hospital, a small hospital, and those two hospitals were non-COVID hospital during the pandemic. The other partners were the Centro Distrital Segurança Social, which is the Social Security Region Administration, and the Agrupamento Centros de Saúde Feira Arouca, which is the primary care providers in our region. So in our hospital we had the first patient diagnosed on the 14th of March, sorry. And we had to face these problems that were already discussed in previous presentations: the lack of scientific knowledge, disinformation and fears. Who remembers those terrific videos and the fake news from China, where people were walking on the streets and falling down, supposedly by COVID? And these fears, our staff and professionals, although we have a lot of knowledge in healthcare, but we didn't know that. We felt like the inspiring discoveries of the 15th century that were passing borders of some precedently unvisited jungles where nobody knew what was on the other side of the border. And we had also to work differently with those equipments. We had our the suits that we used in the first times were the suits we had from Ebola, still there in the warehouse. Some of them from Ebola were the first ones to use. So all of this was difficult for the staff. Our institution, of course, we made a lot of changes that were also explained, suspended all program surgical and non-surgical activity, temporary transformed the recovery room from the operation room in an intensive unit care. It was needed. Our hospital, we had 11 intensive care beds before pandemic. During pandemic, we expanded to 42 intensive care beds using this room, and in the second wave, transforming the cantina of our hospital in an intensive care unit in 3 weeks and creating 15 extra intensive care beds. Found the solution for those patients was these patients that I told you was very important. We didn't have a molecular biology laboratory. We weren't prepared for the tests, for the COVID tests. We made it. We created this molecular biology laboratory, which is requested people and requested investment in equipment, and we made it very shortly. Some numbers don't fix this. Till September this year, since March last year, we made 85,000 tests. We had 5,000 positive tests detected in our hospitals, 26,000 attendances in emergency suspected of COVID, 2,050 people attended in our hospital beds since the emergency of COVID, and nearly 500 people in intensive care unit beds during this time. In the first wave, we had a maximum of 115 people in-house in our hospital beds. In second wave, 145, and in third wave, 185. You can see that with a 400 beds hospital, this is huge, because and created a big pressure. So all the beds were needed for the acute patients, and we had to find a solution for those who didn't need those beds. And so we implemented this cooperative partnership with those partners that I said to you. We used an unity of elderly institution that had closed its part of its response due to COVID, so they have some space available. And so we all together with those institutions, we created this this response. The project took into account quality of life, individual satisfaction, dignity, rights and wills of patients to develop a transdisciplinary model to work with, the right identification and diagnosis of individual needs, to make sure the provision of the services identified above were appropriate to particularities of each and every one that was admitted. These people, most of them very poor, most of them very with social problems, and need to be attended with dignity. This was very important for us. The working model contains following stage admission, clinical and technical analysis. At admission, individual care plan was provided according to each patient. During their stay, daily reassessment were carried out. The team that was created included doctors, physicians, included nurses, and some auxiliary staff. And it was people dedicated exclusively to this project. We ourselves, we gave some supervision, technical supervision, and it was very important. Social intervention initiatives took place encouraging permanent contact between patients, families, caregivers and nursing homes, therefore maintaining family bonds. Some of these people, they were in nursing homes, but those nursing homes didn't accept them because they were fear of COVID. They were not prepared for receiving patients of COVID. They were afraid of receiving some COVID positive patients that could infect all the others in the institution. And these first times were very, very severe, very difficult. I would say the level of effort that our teams made in the first wave to deal with 115 patients were much, much, much higher than the level of effort we made in the third wave with 185 patients. Because in the first wave it was, the unknown was much, much critical. And in the first wave we didn't know, we were rebuilding all the way of working. And in the third wave we already knew how to work. And that made a lot of difference. Incentive contacts were made by telephone, video calls, visits, and musical therapy. I would stress this. Using an initiative called Music at the Window, where the music was played outside the building and the patients listened and watched at the window. It created a human touch and people felt very well with that. Both of people, those who could help playing their music and those who receive this human touch. Clinical monitoring, patients monitored by the clinical team that was created and supervised by us and articulated with primary care of the region. Patient clinical progress reported daily with the primary care. Results, this response work firstly received the first patients in end of May, beginning of June, and closed in August. So during this time, we received 21 patients. Seems not so big, but at that time, each patient was huge. And the possibility of giving a response to these people was very, very important for us. Due to their worsening health conditions, 5 patients returned to the hospital, where they were admitted. 2 of them eventually died. After 19 patients met healing criteria and were reintegrated into their family or social institutions. The International Hospital Federation Review Committee selected our project among other and recognized organizations, different countries, and we receive a special recognition for the IHF behind the call of duty for COVID-19. It was very important for our staff. People that worked on this project were very pleased to receive this award, and it meant a lot to all of us. This was a very important project, and COVID is there. We learned a lot of COVID. We learned that although we are prepared, although we work a lot, although we study a lot, there's always something can come over that we're not prepared. And only together we can face those challenges. And this was a small example of how together we can make much more than we can make alone. Thank you.
Thank you, Miguel. And our last presentation will be done by 2 people. Dr. Carlos Cortes, that is a clinical pathologist and the head of department also in the Médio Tejo Hospital Center, that is a big hospital in the center. And it's also head of the Central Regional Council of the Portuguese Medical Association. So, and after you will make the presentation with Rita Coelho, that is that have a master's degree in medicine and is presently also having a residency in clinical pathology. So the floor is yours. Go ahead.
So good morning. I would like to compliment Professor Carlos Pereira Alves and all other speakers, and thank you for your kindness and for your trust to our work and our experience in our hospital. This presentation is shared with Rita Coelho, and I will talk about the first, the beginning, the first phase. This is a concise summary of the presentation, and here we have the characterization of the hospital center. In our district, in the center of Portugal, there is 1 hospital in Santarém. Santarém is the capital of the district, and 3 other hospitals in main cities that are part of the Médio Tejo Hospital Center, Centro Hospital do Médio Tejo, easier CHMT. This hospital center is a medium-sized secondary healthcare institution, perfectly, or maybe almost perfectly, targeted to its area of influence. We can see here, you can see the data about this hospital center. You see the population, the healthcare workers, the financial here in the end. In this slide, these 3 cities, Abrantes, Tomar, and Torres Novas, have hospitals separated by 30 kilometers distance. At the height of the pandemic, Abrantes was turned into a committed COVID-19 unit by moving some departments to Torres Novas. For example, pediatric care, obstetrics, neonatology. But the main emergency, the COVID care, the COVID wards, the ICU stayed in Abrantes. The main laboratory was and is actually localized in Tomar. Routine COVID diagnosis is in Tomar, but the urgent diagnosis remained in the 3 hospital labs. Here, perhaps I think the most important feeling at the beginning of the pandemic, overall social uncertainty, amplified by disorganized, inaccurate, and delayed political decisions. And here we have 3 important challenges for 3 important targets. Establishment of a certified molecular biology lab. I should remember you that the gold standard SARS-CoV-2 diagnosis is the polymerase chain reaction molecular biology technique. Second, between 1,000 and 1,500 output tests per day, and around the clock working. For these 3 challenges, we had 3 response levels: hospital response, community primary care response in our influence area, and 100-kilometer extended area response. The impact of this ambitious contribution is, as you can see, as you can understand, tremendous on the lab activity. But the vision, the strength, the will, the achievement potential, the solidarity between hospitals, the will to help without barriers was common to the different level of leadership in the hospital center. And these qualities and attributes were the key for achievement and success. And here we begin with the first phase in March. The first phase had 2 parts: appointment collection procedures, internal transportation, and results report are in the charge of the CHMT lab, and in other hand, the processing samples were subcontracted to an external private laboratory. Perhaps the pandemic start was the most difficult part. We needed to create a completely new procedure network, work adjustments, team training, new technology acquisitions, specific new molecular biology lab location, reinforcement work. Don't forget that we started with an almost blank sheet of paper. The new lab architecture included more technical staff, more biopathological medical doctors, new molecular biology devices, new specific procedures, a demanding training and focus, new communication links, and an ethical and deontological demand and attention. We had the same laboratory with the same walls, but with a very different way of working. In the second phase was very stimulating for us and rewarding. Suddenly, we had a completely new molecular biology laboratory and a surprising COVID response capability. We could now lay off the private laboratory. And these slides are very illustrative about acquisition of new devices. And like you can see, in the beginning, in the start of the pandemic, our capability is 30 tests per day. Now is more than 70,000 tests per day. This is a timeline, and in this timeline there is 2 or 3 important dates. In March, we start with an external private laboratory. In May, is the beginning of full internal COVID response. In January, since the beginning of the year, with the vaccination process, we have started an humoral immunity study, very important for us. And in August, we start an original cellular immunity study. But this part, Rita, will approach better this part in the next presentation. I think here the most important point is the reception of samples from workplaces, schools and elderly nursing homes. You can see in this picture the difference between May and September of the same year. Our, in the beginning, influence area, and in September, this is our influence area. And the result, about 100,000 tests in 2020. And now, today, is about 170,000 tests, a relevant assistance to other geographic areas, like Lisbon during two or three severe pandemic crises, and an extended community area. Our work is focused not only in covering our patients' influence area, but mainly every patient or institutions requiring healthcare procedures. CHMT is not only a district hospital center, but also an institution part of the national health system. So, in my opinion, our response needs to be national when requested and not only local. And Rita.
Good morning. Now I'm going to talk about the consolidation phase, marked by the constant differentiation of our department. Sorry. So, since October last year, with the appearance of new mutations that conferred greater transmissibility and disease severity, we began testing the SARS-CoV-2 variants, wild type and variants from United Kingdom, South Africa, the Delta from India, and the variants from Manaus, Brazil. Recently, we also have available tests to access cellular immunity. We have 2 important studies in progress to access humoral and cellular immunity in response to vaccination in our hospitals, healthcare workers, and in elderly population. We have also other specific groups in studies. In these graphs, represent the appearance of variants over time in Portugal. On the left, the one reported by the National Reference Laboratory, INSA, where there is a predominance from February to May of the United Kingdom variant, and from June to the moment that the Delta variant emerged. On the right, data from our department, with the 949 sequenced genomes showing the same trend. During this time, workflow documents were created and shared, allowing to quick and easily create, view and edit all the patient-related information, results submission to the Public Health Authority, daily accounting the number of processed samples, and results to the National Public Laboratory, automatic send of mandatory notifications to Public Health Authority, and updates dashboards, regular publication. And can you see? Sorry. In this slide, this is an example of our latest dashboard. There were many challenges, but quality, ethics, and data protection were always a concern. We participate in internal and external quality controls, ensuring reliable and consistent results. We created an ethics group in order to respond to situations that arise. In terms of investment, our hospital invests less than 5 million euros with sending samples to external laboratories, with acquisition of device and reagents, and the lab structure modifications. But on the other hand, performing tests for other areas outside CHMT's area of influence provide us an income around 5 million euros. We also had a little state support around 250,000 euros. As you can see, we did a lot of tests coming from different regions of country. Of the total, we got 8% positive. January of this year was the month that tested the most, where there were really very complicated days. Since the beginning of the vaccination, our department have tried to understand how our body reacts to the virus. We started with the study of humoral immunity, monitoring the level of acquired antibodies over time. As seen in this graph, antibodies increased up to about a month after complete vaccination, but then began a decrease very abruptly. We found that older people have had lower titers. After a month, everyone had antibodies. At the third month, there were a decrease to 80%, and after 6 months, to 92%. But so far, 9 of around 2,000 healthcare workers have been infected after vaccination. Before vaccination starts, CHMT had 320 infected workers. This made us think there was to be something else in our immune system providing protection. Thus, after 6 months of vaccination, we started the study of cellular immunity using the Euroimmune-specific interferon gamma SARS-CoV-2 detection kit that became available worldwide market. This test detects a cytokine, interferon gamma, produced by memory T cells when in contact with the virus. The results are still preliminary, but most people maintain this immunity positive, with no significant difference between age groups. People with low humoral immunity, low antibodies, have high cellular immunity, high interferon gamma. At the 6 months, while the antibodies decrease by 92%, 91% of people have cellular immunity, which seems to be a safe protection against the virus. With the qualification of the laboratory and internalization of diagnosis tests, we were able to provide shorter waiting time and respond to frequent collaboration requests from other institutions, with unquestionable public health benefits. The variant or mutation scan allowed epidemiological monitoring and treatment optimization. The study of immunity will contribute to the scientific community and to assess the need for a possible vaccine booster. In conclusion, initially our department did manage SARS-CoV-2 diagnosis and had to resort to external private laboratories, but that changed quickly. With the lab's ability to expand, it is now able to carry out more than 2,000 tests per day. Everything that was achieved was due to the lab and hospital staff dedicated work. perseverance in search for solutions, and the crucial capability to organize, readapt, and rearrange the lab department. And this is our team. Thank you for your attention and to those who supported us. Thank you.
Thank you, Rita, for
Thank
the
you.
time and for this nice presentation. Put us some problems. Well, we have 15 minutes to discussion. As you know, in the audience, you can put the discussion through a micro or using the technological devices, but we are open that we have any question during these 15 minutes. There was someone over there. Can we give the... Eu não vejo aqui. Tens aí? It's better with the...
Yes, I had a question in relation to cross-border cooperations, because we know that the COVID-19 led to increased cooperation between neighboring countries to take care of patients, for example, if you take Switzerland and France. And I wanted to know if there was a parallel cooperation, a similar cooperation between Portugal and Spain to take care of the increased number of patients. Thank you.
I don't know if any of the members of the panel have a response to your question. So, Miguel.
Happily, we didn't need external help. At the third wave, the European Union found we were facing very big challenges. The number of patients were very, very high. And really by the end of the third wave, some Dutch team arrived in Portugal, but in fact they arrived late and they treated just a few patients, and in fact we could deal with that. With Spain, we didn't have any special cooperation, although Spain was very severely affected in the first wave. What I would stress is that we had a lot of solidarity among the country, because in Portugal the level of effort of all the hospitals were not exactly the same during all the time. Namely, on the third wave, we had a very strong boom in one of the north hospitals, Centro Hospitalar Tâmega e Sousa, and that hospital needed help, and a lot of those patients were distributed by other hospitals in the north region and the military hospital. So we made this distribution within the country. Even on the third wave also, in the area of Lisbon, there was a huge demand also that hospitals couldn't deal in time, and a lot of those, I don't know exactly the number, but for instance, in my hospital, I received 3 or 4 patients from Vila Franca de Xira hospital, for instance, and some hospitals in the north that were not so highly occupied in the third wave received patients from Lisbon region. So we didn't make so big cooperation with other countries, but within the country we made a lot of cooperation.
Yeah. Thank you, Miguel.
Hello, my name is Jarosław Fedorowski. I'm the president of the Poland's Hospital Federation. Pleasure to be here, and congratulations to Portugal. You're the champion. The champion no one can really master with regard to vaccinations, so this is absolutely great. But I have the question to Dr. Vanessa Ribeiro. You mentioned at the very beginning of the pandemic that you made some centralized purchasing with a special procurement. What we had in Poland is that number of ventilators arrived without certification at that time, and also number of other equipment with falsified or no certification. Of course, we know which direction they were coming from, and there was a lot of discussion, political discussion, whether it was the right thing to do so centralized without a typical procurement. And of course, the Ministry of Health would say we didn't have a choice. What is your experience on that? Have you had the same challenge like we had, and how were you able to overcome it? Thank you.
Okay, thank you very much.
Here it's probably better for camera. Okay, so yeah, so at home they can see you better. Okay.
So I was thanking you for your question. I think all countries might have these kind of problems that we have in the beginning of pandemics, with the shortage of materials and the urgent need to purchase materials. So we had the same problem as you. We bought the material we could that were available because most of the things were not available. And what we did was to run tests. And like you in Poland, we also had some quality problems with some equipments. And they didn't go to the hospitals to provide care. So this is mostly what happened.
Okay. I don't know if there is any question from the audience. I have no questions here. I don't know if there are some made by the. But before we.
And just like this, they will appear here if there's some questions.
No, but for the moment there is no questions. No. Apparently we have no questions from online. I think it's important to stress from what we have in these presentations. I think there's one thing that I will ask to all the presenters that is almost universally accepted. The workforce that we have when we begin was already inadequate. With the pandemic, we really arrived to a conclusion that we need to increase the workforce in health hospitals and centers in order to respond to the needs of the population. Let's say one of the problems in Portugal now with our health system is that the demand is much higher than the response that is on the field. So workforce, as we say, we need to look to this very, very carefully. The other thing that I think was important in the first presentation, when you asked to the words more important during this period, there was uncertainty. Margarida is not there, no? Yeah. Esta luz é terrível. This light is terrible. Resilience, but I was very happy that there was also what I mentioned in the beginning, hope. Hope. We need also to go on with the hope. One of the presentations called the attention that we have to involve all the players in this problem, not just the hospitals and the primary care settings, but all the other, even the municipalities, like we have seen in one of the presentations. And finally, I think this last presentation for me, you have a special interest. First of all, have shown that if we have the opportunity to do the things right, if you have the investment like you have in the beginning, that we start from one little thing to a big center. That means that even in the National Health Service, if you have enough financing and enough support, we can do and we can avoid our external dependence for doing many things in this special period doing the tests. But the main for me, I don't know, but I think this the things that we have mentioned, that there is a difference. That say one of these uncertainties is about immunity. Is immunity total or partial? Is immunity how long? Is 6 months? Is 1 year? What is going to be the future? Are you going to have three vaccinations per year as this year? So all these are. But it's quite curious that a lot of questions till now are based in the antibodies, in the antibody response. But what you have shown pretty well is that even if the antibody response have fallen, the cellular immunity is there. So it means that the patient is in a position much better than one before the vaccination. And this, I think, is a very, very important point. And go ahead with your work, because I think we need answers to these uncertainties, and we need to know what's going to be the future, because we are not interested in being vaccinated 3 times per year. So this will be very important. This for me the second part of your work that probably is going to be take care of these results in order to have some ideas. So for me, this I think was a very well successful meeting, not because it was organized by the Portuguese Association, but I think for the presenters especially, and I'm grateful to their disponibility and to their quality of things. To the others, that was quite nice. I'm glad, and we are just in time. It's another important thing. We Latins, we Portuguese, we Brazilians, that usually are attacked because we never match to the time, but we show here that we are learning, and also with the pandemic, we are in time. We are exactly in time, and so if there is any more comments or questions, thank you very much for all. Thank you very much for the audience. Thank you very much for the presenters. And